Hello ladies and gentlemen. Today we will discuss about renal function test, which is also known as RFT and also known as KFT. To assess the functions capacity of kidney, early detections of possible renal impairments, severity and progressions of the impairment, monitor response to treatment. Monitor the safe and effective use of drugs which are excreted in the urine. When should we assess renal function? An older age, family history of chronic CKD, decreased renal mass, low birth weight, diabetes mellitus, hypertension, autoimmune disease, systemic infections, urinary tract infections, nephrolithitis, obstructions to the lower urinary tract, drug toxicity. What to do? Examine. Renal function tests are divided into following: urine analysis, blood examinations, glomerular function test, and tubular test. Simply, the urine RFT is divided into these steps. First of one is urine analysis. The urine analysis. Urine examination is an extremely valuable and most easily performed test for the evaluation of renal function. It includes physical or microscopical examinations, chemical examinations, and microscopical examination of sediments, gross appearance, volume, and color, microscopic cells, cast crystals, bacteria, biochemistry, sodium, potassium, hydrogens, and glucose, pH, osmolarity, proteins, urea, creatinine, and glucose. Urine analysis, microscopic examination, the color, the one of the best or one of the top viewpoint that we see in the urine, normal pale yellow in color due to pigment urochrome, urobilin, and uroerythrin. Cloudiness may be caused by excessive cellular material or protein crystallizations or precipitations of salt upon standing at room temperature or the refrigerator. If the sample contained many red blood cells, it would be cloudy as well as red. Blue green, pink orange red, and red brown black. Methylene blue due to pseudomonas infection and riboflavin. Pink orange red, hemoglobin, myoglobin, phenylephrine, porphyrins, and rifampicin. Red brown black, hemoglobin, myoglobin, red blood cells, hemognostic acid, L-dopa, and melanin, methyl-dopa. Color of urine depends upon its constituents. Volume: normal 1 to 2.5 liter per day. Oliguria, a condition in which greater than 400 milliliter per day seen in acute glomerulonephritis and renal failure. Polyuria, urine output more than 2.5 liter per day, is known as polyuria, seen in increased water ingestions, diabetes mellitus and insipidus, and urea. Urine output less than 100 milliliter per day, seen in renal shutdown. Specific gravity, measured by urinometer of refractometer. It is measure of urinary density which will reflect the ability of kidney to concentrate or dilute the urine relative to the plasma from which is filtered. Normal 1.001 to 1.050. Specific gravity, osmolality per kg. Increase in specific gravity seen in low water intake, diabetes mellitus, albuminuria, acute nephritis. Decrease in specific gravity is seen in absence of ADH, renal tubular damage, isocyaninuria, persistent production of fixed low specific gravity, urine isometer with plasma despite variation in water intake. pH. Urine pH range from 4.5 to 8. Normally, it is slightly acidic, lying between 6 to 6.5. After meal, it becomes alkaline. On exposure to atmosphere, urea in urine splits, causing ammonia, NH4 release resulting in alkaline reactions. Microscopical examination. A sample of well-mixed urine, usually 10 to 15 ml, is centrifuged in a tube to relatively low speed, about 200 to 3000 rpm revolution per minute for 5 to 10 minutes, which procedures concentrate of sediment, cellular material at the bottom of tube. A drop of sediment is poured onto the glass slides and thin slice of glass cover placed over it. The sediment is first examined under low power to identify crystals, casts, squamous cells, and other large objects. Casts are plugs of material which causes the individual tubules. The number of casts seen are usually reported as number of each type found per low power field. For example, 5 to 10 highly cast, low cast, LPF, low power field. Presence of granular cast, RBS bacteria, glucose, albumin, and ketone bodies is abnormal. Hematuria is the presence of abnormal number of red blood cells in urine due to any of several possible causes. Glomerular damage, tumors which erode the urinary tract anywhere along its length. Kidney trauma, urinary tract stones, acute tubal necrosis, upper and lower urinary tract infections. Red blood cells cast in urines, white blood cells cast in urines, urinary cast, Howling cast, erythrocyte cast, leukocyte cast, and granular cast seen in the picture. Crystals. Tyrosine crystals with congenital tyrosinosis. Leucine crystals in patients with severe liver disease or with the maple syrup urine disease. A. Calcium oxalate. B. Uric acid crystals, triple phosphate crystals, and amorphous phosphate cysteine crystals. Blood examinations done to measure substances in blood that are normally excreted by kidney. The levels in blood increase in kidney dysfunctions. As a marker, renal function, creatinine, urea, uric acid, and electrolyte are done for routine analysis. Serum creatinine. Creatinine is the breakdown product of creatine phosphate in muscles, and it usually produced at a fairly constant rate by the body depending on muscle mass. Creatinine is filtered but not reabsorbed in kidney. Normal range is 0.8 to 1.3 mg per deciliter in men and 0.6 to 1 mg per deciliter in women. Not increase above normal until GFR is greater than 50 milliliter per minute. The method most widely used for serum creatinine is based on the GFR reactions. The reactions occur between creatinine and the picrate ion formed in alkaline medium, sodium picrate. A red-orange solution developed with the red color metrically at 520 nanometer. Increased serum creatinine, impaired renal function, very high protein diet, anabolic steroid users, very large muscle mass, bodybuilders, giants, acromegaly patients, rhabdomyolysis, crush injuries, athlete taking oral creatine drug, probenecid drugs, trimethoprim, and amyloidroid. Blood urea. Urea is the major nitrogenous end product of protein and amino acids catabolism produced by liver and distributed throughout intercellular and extracellular fluid. Urea is filtered freely by the glomeruli. Many renal diseases with various glomerulotubular interstitial or vascular damage can see an increase in plasma urea concentration. The reference interval for serum urea of healthy adult is 10 to 40 mg per deciliter. Plasma concentrations also tend to be slightly higher in males than females. High protein diet causes significantly increase in plasma urea concentrations and urinary excretion. Measurements of plasma creatinine. Serum uric acid. In humans, uric acid is a major product of catabolism of the purine nucleosides, adenosines and guanosines. Purines are derived from catabolism of dietary nucleic acid and from degradations of endogenous nucleic acid. Overproduction of uric acid may result from increased synthesis of purine precursors. In humans, approximately 75% of uric acid excreted in the loss of urine. Most of the remainder is excreted into the GIT. Glomerular function test. The GFR is the best measure of glomerular functions. Normal GFR is approximately 1 to 5 milliliter per minute. When GFR decreases to 30% the normal, it is moderate. Renal insufficiency patient remains asymptomatic with the only biochemical evidence of a decline in GFR. As the GFR decreases further, severe renal insufficiency characterized by profound clinical manifestations of urea, anemia, and chemical abnormalities such as acidemia, volume overload, and neurological, cardiac, and respiratory manifestations. When GFR is 5% to 10% of normal ESRD condition. Insulin clearance and creatinine clearance are used to measure GFR. Creatinine clearance, a simple, inexpensive with bedsides estimated of GFR. GFR is equal to CCR, QCR, star urine flow rate, milliliter per minute. PCR, normal 100 to 120 ml per minute. Decrease renal reserve 6 to 100 milliliter per minute. Mild renal impairment 40 to 60 milliliter per minute. Moderate insufficiency 25 to 40 milliliter per minute. Renal failure less than 25 milliliter. ESRD less than 10 milliliter per minute. These are the formula deriving the GFR. Tubular function test. Urinary concentration test. The ability of the kidney to concentrate urine in the test of tubular function that causes be carried out readily with too minor inconvenience to the patients. This test requires a water deprivative patients for 14 hours in healthy individuals. A specific gravity of greater than 1.02 indicate normal concentration power. Specific gravity of 1.008 to 1.0110 is isotonic with the plasma and indicate no work done by kidney. The test should not be performed in dehydrated patients. Vasopressin test, more patient friendly than water deprivative test. The subject has nothing to drink after 6 p.m. At 8 p.m., 5 units of vasopressin 10-8 is injected subcutaneously. All urine samples are collected separately until 9 a.m. the next morning. Satisfactory concentration is shown by the at least sample having a specific gravity above 1.020 R or osmolarity above 18 millosmolarity per kg. The urine plasma osmolarity ratio should reach 3 values less than 2 are abnormal. Urine dilution, water load test. After an overnight fast, the subject empties his bladder completely and given 100 ml of water to drink. The urine specimen are collected for next fraud. The patient's empty bladder completely on each occasion. Normally, the patient will excrete at least 700 milliliter of urine at least for and at least one specimen will have a specific gravity less than 1.004. Kidney which are severely damaged cannot excrete a urine of lower specific gravity than 1.010 or a volume above 400 milliliter in this time. The test should not be done if there is edema or renal failure. Water intoxication may result. Para-amino hypuric acid clearance. Maximum security capacity of tubules for pH is nearly constant above 18 mg per minute. A decrease in the TMPH indicates tubular damage. Micropuncturing various parts of tubules and analysis of fluid for volume and composition. Microscopy test. Study slice for renal tissues of different depths. Microelectrode study measuring the membrane potential of tubular cells. Clinical significance of RFT in AKI. The referral criteria proposed by the Acute Dialysis Quality Initiative Group 8 the stages of patients with AKI previously ARF. Risk GFR criteria urine output. Increase creatinine multiple by 1.5 or GFR decrease less than 25%. Urine output less than 0.5 milliliter per kg or higher multiple by 6 hours. High sensitivity. Injury in the same reaction failure. High specificity. Loss, persistence, ARF, complete loss of kidney, ESKD, and stage kidney disease 3 months. Adenodum. Novel marker for non-invasive estimations of glomerular filtration rate and early renal impairment. Cysteine C. Cysteine C is a non-glycosylated basic protein produced at the constant rate by all investigation nucleated cells. It is freely filtered by renal glomeruli and primarily catabolized in the tubuli. serum crystalline concentration is independent of age, sex, and muscle mass. It has been postulated to the impairment provided by serum glomerular filtration rate.